Okay. So I think it's 5 past, so and colleagues can join us as the presentation starts, but I would like to start because some are already waiting for 5 minutes. And I would like to say that both speakers, we know each other for a very, very long time. You've seen the brief bios in the materials sent around. For Finbar, I start with Professor Finbar Allen because he will do the first presentation. You know that he's back in his beloved Ireland, and after having been in different places, Singapore was the last one, and he has a long established research coming not from a dental public health background, but thinking very much as a dental public health professional. So he is, I would say, more sort of the aging geriatric agenda, if you like, his starting point, but actually he's very much into subjective outcomes. Sorry, I'm not reading Finbar what is here. I'm just improvising a little bit. And has been a critical in his approach throughout, and I expect that we will see something like that. I wanted to say that this whole webinar was very much a quality of life issue because it was conceived, believe it or not, during the IADR last meeting in New Orleans. And you can say that IADR is not necessarily about quality of life, but we were all watching an excellent NBA game, the Pelicans versus the Cleveland Cavaliers. And this is where we started talking about it, as if we had nothing else to do. And I'm really happy that both speakers agreed, and it wasn't just a positive answer to get out of a tricky situation. So I'm really happy that Finbar is going to talk to us today about how quality of life measures or oral health related quality of life measures, to make our life a little bit more complicated, are used in clinical studies and how we can interpret the data. Finbar, the floor is yours, and we're looking forward to it. Thank you.
Okay, thank you, George, for that kind introduction. I'm glad you clarified the geriatric and aging part in relation to us was in relation to our research, not us. But anyway, welcome everybody, and I'm very grateful for the opportunity to do this presentation for you. Let me just get it into the proper show here. So my task is to talk to you about the use of these measures in clinical studies and how perhaps we should interpret the data. It's an interesting topic, I think, because as George said, I'm actually not a dental public health person. I'm a prosthodontist with an interest in this area. So a lot of what I'm going to talk about is reflective of my experience in using these measures in clinical studies. So as you mentioned, I'm back in Cork now, a lovely city, and we have a high quality of life in this region. It's a beautiful area. We work in a very nice university, and one of my favorite places in the world is this food market here in the center of the city. I'm delighted to be sharing the floor with my good friend Satu. This is a picture of us at a session in an academic session in Finland some years ago when we both had a very good time, but I have no conflicts of interest to declare. So the presentation, just to give you a quick overview, is why is it important to measure this? And I'm going to say a little bit about the context and the era of value-based healthcare and framing why I think it's important to measure this in dentistry. Obviously, what are we trying to measure? But mention something about some of the methodological considerations that we have to think about. And then I'm going to illustrate some of the points using some examples. So I'm going to start with this is, I think, probably familiar to most or all of you, about how do you describe something as a public health problem. I've always liked to use this slide. It's where it is widespread or serious, if it carries severe consequences or costs to populations or individuals, and if there are effective methods available to prevent, alleviate, or cure it. So we all know that dental disease and the ultimate manifestation of dental disease is tooth loss is highly prevalent. I don't need to overemphasize this. And it's very costly to manage this. And everywhere we're seeing where it's reported very, very high costs of managing the consequences of dental disease. And these are some of the figures from Europe. They're probably a little bit out of date now, but it gives you a flavor of the sort of huge amount of money that treating dental disease costs us. And treating disease is where we're currently at. We're not so effective yet at mass prevention of disease. And over the generations, we have used, and quite rightly, tried to measure disease processes like DMFT, BPE, etc. And these provide valuable information, but they are actually only measures of stages in pathological process. They do not actually tell us anything about the day-to-day impact of disease on people's daily living, their well-being, their quality of life. They're not especially sensitive to fluctuation in chronic conditions. So things like, for example, tooth loss and edentulosum, how does that change over time and the impact of it? And obviously conditions like chronic temporomandibular joint disorders. So our objective measures that we need to use to measure disease processes don't actually tell us any information in relation to these impacts of these on day-to-day living. And of course, over time now we're getting much more into patient-centered assessment and the need to develop frameworks which include not just disease and condition status, but things like psychosocial function and the need to capture information on this at both individual and population level, I think is quite well accepted now. And it's not a new construct. This is from a paper published in the early 1990s, where the advocacy for use of patient-based assessment, and this is where we sometimes need to think about some of the terminology used, patient-based assessment, patient-rated measures, measuring quality of life, measuring health-related quality of life, measuring oral health-related quality of life. So I'm going to use perhaps the terms patient-based assessment and oral health-related quality of life a little interchangeably here. But the advocacy for this was that you could use it to monitor health status. You could potentially use it to target resources towards those in the population which perhaps might benefit most. You can use it as an outcome measure in clinical studies and just as a general advocacy for health, and in our case, oral health. So there's been a huge uptick, if you like, in the development of this area over really the last 30 or so years. So as I mentioned earlier, my background is as a prosthodontist, and I deal a lot with tooth loss and its consequences. And it pains me to say as a prosthodontist that we can only moderate the consequences of tooth loss with prosthetic dentistry. We cannot reverse engineer the benefits of having a full complement of natural teeth. And most of the time I'm dealing with a chronic disabling condition for which there is no cure. And the ultimate manifestation of that is edentulosness. So it's a chronic disabling condition for which we have no cure. And the best we can do is moderate the consequences. And the prevalence of edentulosum is decreasing quite sharply around the world, but the prevalence of severe amounts of tooth loss is actually quite high, as these data show you here. And if you look at the incident cases on the right-hand graph, you will see that it peaks around about the 6th decade of life. And this is at a time which is not optimal for adapting to things like dentures. And it's a very tricky problem in restorative dentistry and oral rehabilitation, which is managing significant amounts of tooth loss at this age of life where there's no experience of wearing any form of prosthesis. And staying on the theme of impact, this is again an old classification from the early 1980s from WHO, the ICIDH classification. But the loss of teeth is loss of a body part, and potentially causing disability, which is preventing people from undertaking the day-to-day average tasks such as eating and speaking, and then handicap, the broader psychosocial impact, your loss of autonomy, loss of ability to interact and socialize. It severely impacts food selection and health-related quality of life, and in some cases, even educational attainment. So the functional and psychological consequences of tooth loss can and often are severe. And you see this in qualitative research as well, where some very emotive language is used by participants who are partially dentate or edentate, who have lost their teeth. And this is not something that is as well tolerated as it used to be. Pre-war generations accepted perhaps tooth loss much more readily than the post-war baby boomer generation and Generation X individuals. So it has quite significant consequences in that regard. And again, when we look in, systematically at quality of life impact reports on tooth loss, it's fairly obvious that the more natural teeth you've lost, the bigger the impact. If you're missing anterior teeth, that's really bad, but also multiple missing posterior teeth and lack of functioning occlusion, again, has a negative psychosocial impact and impact on quality of life. It is rather interesting, and at population level, I think, and these are some data published by Gary Slade and Ann Sanders about 10 or so years ago now, from the Australian National Health Surveys in the early 2000s. And if you look again at the plot here, which is on the x-axis, you've got the age groupings, and on the y-axis, the prevalence of impacts, and the more prevalence, obviously, the worse the oral health-related quality of life. This is using the OHIP. You can see that there's a downward gradient, which gives the indication of a reduction in quality of life impact as you get older. Now, this has been presented potentially as a sort of a disability paradox, that as you get older, you get better in terms of quality of life. I think this is not so straightforward, but certainly impacts are not well moderated by wearing dentures, because the bottom line, the dotted line at the bottom of each of these graphs, is actually dentate individuals. So what this tells us is that it's better to keep your natural teeth, and as many as possible, in good health. There'll be some impact with dentures, but it won't moderate the effect of the tooth loss completely. And it may not be so bad in older age. That's what it looks like cross-sectionally. There are not that many longitudinal studies, but those that are there present a slightly different picture. This is a Japanese study. And again, it monitored quality of life impact of tooth loss over a 7-year period. And it showed actually that loss of teeth and reduction of bite force in this Japanese population predicted a decline in oral health-related quality of life. So I think tooth loss generally will have a bad effect. It doesn't affect everybody equally, but it does, generally speaking, have a bad effect. So that brings us then to, are there effective methods available to prevent, alleviate, or cure it? Now, I'm going to focus a bit more on the alleviate or cure it end of this. And this is where I think things become quite important, because we now have to think, especially if you think of the context, for example, of the National Health Service, where choices have to be made about where to allocate resources, then there's obviously significant interest in the cost of care and the value that you get for that. So this concept of value-based healthcare, this sort of started to come out of the United States and the Harvard schools back in probably the early 2000s, I would say. And Michael Porter is one of the big proponents of this, because it's widely recognized, obviously, that pouring money into health services without taking a look at outcomes and how to manage costs and get better outcomes with the money that's being spent is no longer sensible or acceptable. And value-based healthcare, it looks at the concept of value. So value is essentially here, I've highlighted here at the bottom, it's a ratio of outcomes to cost. But there's a number of different stakeholders whose inputs and consideration have to be considered in this equation, starting with patients, but also providers, payers in insurance-based systems, suppliers of care, which are the healthcare providers, and obviously society in general, whose taxes are paying for these services in publicly funded systems. And a consistent theme across this is outcome and patient outcomes. So getting better outcomes from a clinical point of view, yes, but also from a patient perspective, their input into this, is it making their lives better? And at what cost is that? And that has to be factored into deciding whether you actually are getting value for the money that is being spent on the healthcare system. So that kind of points us in the direction of having to look at things more holistically. So again, in my field, again, of prosthodontics, there's been a huge emphasis on the top part here. And this is just adapted from Spilliker's clinical trials book. Longevity and survival of restorations has been a big thing and been the focus of much of the research, perhaps a bit on the functional impact, but nowhere near as much until recently on the patient-rated impact or psychosocial impact, and certainly very little on the economic impact in terms of cost effectiveness, cost utility, etc. So I think in healthcare now, we have to be looking at these things in a lot more detail than we have in the past, because it's not just about survival of treatments and how long they will actually last. So patient-based assessment is, I think, now becoming something that's not just a little desirable, sidelined, interesting extra. It's actually becoming an essential measurement tool in how we evaluate healthcare, including oral healthcare. And things like quality of life measures have been developed a lot over the years. Some have been used more widely than others. But I think there's been a tendency perhaps to use a lot of these measures without sufficient regard to their measurement properties and how to use the data and how to interpret the data. So, for example, we tend to present things as means quite a lot. That's a fairly standard presentation of summary data. But in quality of life outcome measures, there's a very wide distribution and very big heterogeneity in these data. So if we're reporting things as means, what it tends to do is it masks the fact that both deterioration and improvement are occurring simultaneously. A very simple example of this is someone can report a pain impact pre-treatment, and you remove that tooth and it gets rid of the pain, but you substitute a gap for it, so there may be a functional impact. So the net gain potentially could be nil. And this is just a very simple example, but improvement and deterioration can and does happen at the same time. And are we and should we be interested in capturing that? And I think we should in clinical studies. There is a tendency and assumption that all benefits, individuals in the study will benefit to the same degree, but that again is not actually the case in patient-rated measures. As a prosthodontist, I know that from actually treating patients that the people you think you've helped a lot don't actually come back and say you have, and vice versa. It's a curious thing when you take in patients' perspectives on this. And then at just a practical level and the practical utility, a lot of these measures are very long, like the OHRQ, for example, is 49 items. Now, that's far too long to use in the clinical context. So there's been obviously a push to reduce the number of items. And the OHRQ was the original short form. But it's a known fact in psychometrics that if you remove items from a measure, you will reduce its sensitivity or responsiveness to change. And as responsiveness to change is a key thing in clinical studies, looking at does your treatment affect and cause a change, then that might cause you a problem. So some measures are better than others at measuring change. And it's important to understand that when you're choosing which measure to use in any form of clinical study. I've mentioned the term responsiveness or sensitivity to change, and that is the ability of a measure to detect change when the change is likely to have occurred. And that's a very desirable property in a health status measure if you're using it in a clinical trial. But sometimes the measure may not contain items or questions of interest, if you like to phrase it that way, of a study that looks at, for example, effective tooth loss. So there are some missing items like chewing measures or chewing items in the OHIP-14. So it doesn't actually measure change in chewing capacity, for example. Those items were removed in the construct of the OHIP-14 when it was being reduced from 49 items. Another issue is again how to interpret. We do use statistical significance for the most part, but sometimes change which is statistically significant may actually not be clinically meaningful or relevant to a patient. It should be borne in mind that quality of life scores are actually intrinsically meaningless. They don't actually have any benchmark. Like, for example, measuring blood pressure, we know that a certain level of diastolic blood pressure will increase your risk of things like cardiovascular accidents or strokes. Whereas if the quality of life measures don't actually have that benchmark, they're intrinsically meaningless. So one area of interest in this is can you detect what's known as the minimally important difference, or MID? And this, again, isn't a new idea. This was described approximately 35 years ago in this publication here. And essentially it's defined, it has a long definition, but a summary of it is the smallest difference in score which patients perceive as beneficial and which would mandate a change in the patient's management. So David Locker and his group in Toronto published a paper which described the MID for the OHIP-14, and it was 5 scale points. So that would mean that if you change your score from, let's say, 19 to 24, that would probably have a minimally important difference to the patient. And if it was a reduction or an increase in either direction, positively or negatively. And there are a variety of ways of actually calculating a figure to give you an indication of what the clinically relevant difference actually is. There are internally referenced methods, which are based on the distribution of the data, and they're essentially ratios. So there's an effect size and a benchmark. 0.2 is a small change. Greater than 0.8 is of a standard deviation of change is a large change and likely to be very meaningful to the patients. Standardized response mean is the same idea, just a different way of calculating the score. And these do depend on the distribution of the data in your data set. Externally referenced or anchor-based methods are another way of doing it, where you benchmark your change score in your quality of life measure against what you would describe as a known anchor of change. So global transition scales are used for this. And generally speaking, there are positive and negative changes around the midpoint of no change. And you then tag your categorical scores on this transition scale against the change in your quality of life measure. And that will hopefully then give you what's known as the clinically MID, minimally important difference. And there are a few papers here at the bottom, and George has published one, I published another, which have calculated MIDs for different measures and used them in clinical studies. So I think it's very important to actually First of all, beware that clinical relevance is the most important, I think. Statistical significance is not as relevant in these types of studies. I think it's important to report those in publications. And for example, in my own case, if I'm asked to referee a paper now of a clinical study using these as an outcome measure, I will insist that they actually calculate some form of interpretability score, be it an anchor-based method or a distribution-based method. And this is just a working example. Again, it's an older study now. It's a study in asthma where a treatment was used as a management of an asthma condition. And this is an asthma scale here, compare pre and post treatment, the TX2 minus X1. And you can see in a number of these scales highlighted in yellow, there was statistically significant change. But they also calculated the clinical relevance. And in fact, the only scale that had a clinically relevant change was the pain one highlighted in green. So you could have achieved statistical significance, but the patients would have not perceived that to be meaningful to them, i.e. no change. Other challenges we have to think about is things like response shift. So this is where essentially a participant's perception of an intervention is different at different points in time. So, for example, if someone is edentulous and they've been wearing conventional replacement dentures, and then there's a discussion about the use of implants, they may reframe how they feel about their current status depending on this new information about what might be possible for them with implants. So there's a reevaluation, potentially a recalibration of their score or of their perception. And that can have an impact on when you're measuring in the clinical trial, either masking improvement or more likely masking deterioration. And it is important just to bear it in mind that people may reframe how they feel about things depending on the information they receive. There's also the possibility of regression to the mean, which is essentially people will just, in answering these questionnaires, will just regress to the mean, and again, which may mask change. And the only really good way, I think, of controlling for this is to ensure you would use a control group in a study because it will affect both the same. So let's just give a few contextual examples. Again, partially dentate older adults. These can be a bit of a mystery. Patients, particularly those who have missing posterior teeth in the mandible or are partially dentate, often will not wear dentures provided for them. That can be approximately 40% in some of the reported studies. So is that because they don't like the dentures? Is it because they feel they don't need them? Or is it just that they're not so happy to be with a reduced dentition, but the prospect of wearing a denture is worse than the actual state that they're in? The cure is worse than the disease, so to speak. And why do dentists view from patients so much? Because I guess our frame of reference is different to the patients. So the shortened dental arch concept or functionally oriented treatment planning is something that has been developed a lot over the years in relation to managing these partially dentate patients. And a colleague of mine, Prof. Jerry McKenna, he was my PhD student, did this work a good number of years ago, where we did a randomized clinical trial to look at outcomes of partially dentate state restored with dentures and partially dentate state restored to a shortened dental arch, using things like resin bonded bridge work to fill anterior gaps. And we compared the two, and one of our outcomes was quality of life, and we used the OHIP-14 for this. And just to orientate you again, on the x-axis of this graph is the timeline, so it was from 0 to 2 years of follow-up. And on the y-axis, the prevalence of impacts. The higher the prevalence, the worse the quality of life score is. And we had 4 groups, but essentially I want to draw attention to them in pairs. So I want you to look at the green and the red together sorry, the blue and the red together, and the green and the purple together. So the green and the purple were a community-based day center attending group, and the blue and the red were dental hospital patients. So they all started off at pretty bad quality of life in the OHIP. They had their treatment, huge improvement down to the first month. And then over time, you can see the denture groups starting to rise upwards again, heading back towards where they came from, whereas the shortened dental arch groups stayed fairly flat throughout. So that told us that the quality of life impact was significant and sustained in the shortened dental arch group. It was significant but not sustained in the denture group. And there are lots of reasons why, and perhaps we can discuss that later. We were also interested in the cost effectiveness of this. So this is one of the ways you can use these data. How much did it cost to actually achieve the minimally important clinical difference? And it was significantly less in the shortened dental arch group than it was in the removable partial denture group. So what this helped to tell us was that in a fairly common clinical presentation with different treatment options, in an older patient group who were fairly high susceptibility to new disease and not likely to look for complex treatment, that the shortened dental arch approach achieved equal functional outcomes for less cost and better quality of life impact sustained over time. So I think that's quite important potentially to policymakers to consider. Again, the edentulous group, we have lots of different treatments for them now. And again, it is one of the great mysteries of the modern world, how people wear complete replacement dentures. I've been making them for nearly 40 years for patients. I still to this day don't understand how so many people tolerate wearing these things, but they do. And I think that is important. A lot don't. And there was, you may be familiar with this publication from about 20 odd years ago, where a group came up with a consensus statement. And they wanted to advocate for the minimum standard of care for edentate adults to have a ball implant or 2 implant retained overdentures in the mandible. Now, they were quoted a lot of randomized clinical trials for this, and there's a lot of good reasons to go down this route. So if we look at it, your preservation of alveolar ridgewood implants is much better. Food selection and perceived chewing difficulty improves, but not in all patients with these, but it does improve. Randomized clinical trials showed a quality of life improvement that was substantial and significantly different to conventional treatment, but there are lots of methodological problems with those studies. And again, we can discuss in more detail later on. But there's a high selection bias for randomized clinical trials where you offer people the option of implants and then randomly select them into the denture group. So that is an issue. But potentially, they're very high cost, but is that moderated by all these gains, quality life gain, health gain, anatomical gain, and potentially reduction in morbidity? And in randomized clinical trials, and this would be one published about 12 years or so ago, again, a 2-year follow-up, use of the OHIP as an outcome measure, comparing implant overdentures and conventional dentures, more than 170 participants, and average age of 71 years. So they're an older group of people. And again, very similar at T0, which is baseline, and big improvements, but interestingly, big improvements in both groups. So less improvement perhaps, but 0.8 and an effect size is a very big change. So I would say that actually there was a huge improvement in that group, even though it's bigger in the implant overdenture group. But I think you've seen both patient groups here improve substantially with different forms of treatment. So I don't think it's right to say that there's the statistical significance and difference here is what you should be focused on, because I think there is a statistically significant difference between the groups. The effect size is very similar and it's very large. There are problems, as I mentioned, with RCTs. You get a lot of selection bias. It's very difficult to do this, where you randomly assign people to treatment, because people who put their hands up for randomized clinical trials for implants are hoping to get implants. And if they don't get them, they're likely to respond in a way that affects their answers. And obviously, not a great degree of generalizability either. This is standard with randomized clinical trials. So effectiveness, where we're looking at this in the so-called real world, very little work on this, but this is a big multi-center study that I was involved in some years back. We had 8 centers. Again, we compared dentures with implant overdentures, and the OHIP was used at baseline and 6 months post-treatment. And lo and behold, if I just got to draw your attention to the bottom of we're highlighted yellow, and these are effect sizes. We were in 3 different parts of the world: North America, South America, and Europe. The effect sizes are very substantial, and both treatments actually worked. So I think that is important. Both worked. There was a higher percentage of deterioration, yes, in the conventional denture group. They got a little bit worse. More people got worse than got better than in the implant overdenture group. So that shows you the difference within patients. Maybe explained, we felt, by not being able to afford treatment. Maybe didn't get the treatment they wanted because they didn't have enough bone to put implants in. We don't know that for sure. We can only speculate. There was a degree of cultural variation. But importantly, good treatment worked for the majority of the people in both treatment intervention groups. So what I think we could conclude at the present time is that oral health-related quality of life measures definitely help us to understand the impact of tooth loss. Potentially, they can be used to target treatment likely to the biggest impact, because there are studies which do show that things like implant overdentures, for example, they do have a very positive impact, but they won't have the same impact for everybody. So in a publicly funded system, it behoves us, I think, to try to identify those people who are going to get the best improvement, identify those subgroups. There are some methodological challenges. I think it's important that you're aware of the measurement properties of the measure you're using. Some are very good discriminant validity, which is very useful in cross-sectional studies where there's a reasonable number of items with a low prevalence reporting. That's useful to segregate out subgroups, and maybe Satu might mention this in her presentation. But in clinical trial studies, they have to be short enough to be practical to use, but have the right questions and the right number of questions of items that are likely to be changed or affected by the intervention that you're planning. And obviously referencing back to literature on this would be very advisable. And I think it's very important, as I've hopefully showed, that sometimes statistical significance might be there, but it's not actually that meaningful. It's important to have some form of reporting of clinical relevance and to actually, I think, get the right interpretation. So with that, I'd like to say thank you for your kind attention, and I look forward to further discussion. I've just put this slide up largely for George's benefit, because I get to see Bruce Springsteen in Cork fairly often, and this is a picture I took here about 2 months ago. Sadly, the sunshine is not what I see usually in Cork. I took that photograph in Mallorca, but I like the look of it. So with that, I thank you for your attention. Thank you.
Thank you very much, Finbar. That was really lovely, and a beautiful sort of really extensive set of issues you managed to touch in a very limited time, which makes life for Satu very, very simple. It's such a low bar to achieve. Unless there are questions for clarification for Finbar, I hope we keep questions for the discussion later. If there are, please say so. If not, means everything was clear. We did understand that Finbar values quality of life in terms of good music and sea and sunshine, also a food market in the beginning. So yeah, it's all very good. What he didn't say is that him and Satu are good friends and colleagues for many years. And actually, he put a paper there that we wrote together many, many years back. And Satu doesn't know it, but she is responsible for instigating that paper because, well, not herself, but the Finnish Society of Polonia had invited a lot of us to talk about quality of life and discuss. And she was the perfect host, looked after everyone, and left 4 of us in the bar. And in Helsinki, it's very difficult to go out. So we stayed in, we obliged, and we started talking about something that ended up in a discussion about interpretability. So I think it's a very natural now to move from what happens in clinical settings into what happens in populations. And it's a real pleasure to have Satu to present that. I don't need to introduce Satu to an EADPH audience. She's there in almost every conference, as long as I remember. And actually, I think the first time we properly met was when I think Hannu was your PhD supervisor, Hannu Hausen. But he introduced us when you were in Oulu, not in Kuopio. So many, many, many years back. And Hannu has been one of the leading figures over the years, particularly in the first stages of EADPH. Satu has spent all her career studying 2 things she doesn't experience. One is oral impacts. She has a really good quality of life. And the second is dental anxiety. She's the most calm person you can imagine in your life. So without further ado, I would like her to take the floor and introduce the topic about how the challenges in measuring quality of life in populations. And I think it's not just the challenges, it's also opportunities you're going to talk about.
Yes, thank you very much, George, for your very kind words. And yes, indeed, we 3 of us, we've been around in the quality of life circles for some time and having some good quality of life. And I start sharing my presentation. I hope you all see it properly. And we do see some sunshine here in Finland for some reason this year, even in September. And I'm going to give you some examples of the population level studies. Just a little bit about myself. I'm currently a professor of community dentistry in University of Turku and very much public health person, training specialist, undergraduate and postdoctoral, examining them. I think my main public health advocacy is currently being a member of National Nutritional Council, which makes the national recommendation representing oral health and then some other issues also. And I also do not have any conflict of interest to declare. I'm coming back to a very old paper to which I base my lecture. Why measure? And I have put oral health related quality of life at population level and what context. And interestingly, this paper by Ibrahim was first time presented in a EADPH conference in Porto by David Locker, who was the pioneer on this area. And I went through the paper again. I saw that actually it has a lot. Still, it holds valid. And why do we measure oral health related quality of life at population level is monitoring population. Finbar also gave some examples because then it's a question about how big is the population. I'm more talking about the national level or big population. But then we can have a spatial comparisons, time trends. Then we can evaluate effects of health and social policies. So we have interventions, but not clinical interventions, but other interventions which might have an effect on health-related quality of life. And it's also a question of allocating resources, just like it is with the clinical studies. It's allocating resources in relation to need. It's also identifying target populations on a bigger scale. I put there my own idea about that. Sometimes it's good to have population level data to test theoretical constructs and associations. And Ibrahim puts on his paper also why measure in oral health related quality of life at individual level. And of course, they were the things that Finbar mentioned: diagnosis of the nature and severity of disease, assessing prognosis. But if we think about evaluating effects of treatment, we can also kind of compare those things on a population level and also discover some etiological factors which are seen in a bigger populations. So these are very, very interesting issues, somehow overlapping. And I'm going to give some examples how we have been working on those issues. And as Finbar told, there are always aspects of validity. And I refer to this very nice book, which I've read a lot. It gives you, so if you can have an access to that, it helps you in going through on issues of validity and reliability and how the measures can be used and how they shouldn't be used. The problem of reading the thing is that you can really dive deep into psychometrics. So you can come into a situation that, have I tested this factor structure of this specific method on this specific populations? Are the measurement invariances similar enough? Can I use this to compare different populations? And if you go to very strict statistical issues, the answer is always no. You need another study to test the measure. And that's an never-ending road. And you have to come to a situation that when it's good enough. A good thing about population studies is that the large samples may balance the errors of classification to false and positive cases, and then they can lead to roughly accurate estimates on the extent of the problem, bearing again in mind that we have to know what is the extent of the change. They can decrease the effect of confounding also because if we have large enough a population. On the other hand, if we look at the statistical significance, we can easily find in big populations statistical significance which is practically meaningless. So again, it's a question about knowing how to interpret your data. The good thing also is that major decisions are seldom made based only on the measures and results of the quality of life measures. And then I go for the examples. This is an old paper by a group of hippies, which was Finbar, Jimmy Steele, Gary Slade, and Sanders, Nigel Nuttall. Lisa Suominen was also part of that group for some time. And actually, I just noticed that it's 23 years since we met in Newcastle first time, just on the date when the towers collapsed in New York. And this is one of the papers from that group, when we started looking at oral health related quality of life. And by that time, by the way, we discussed whether oral health impact profile, OHIP14, can be called a quality of life measure, or should we just call that we are measuring subjective impacts. This is just showing how things change, because by that time we knew that this is a short form. And most of the quality of life measures are based on the theoretical model. So it's a WHO model which David Locker put into the context of oral health. And so it means that the disease causes some kind of impairment, which can lead to functional limitation, pain and discomfort, disability, which can be physical, psychological, or social, or it can lead to complete handicap. And Nigel Nuttall did the analysis and looked at the different samples, so Australian edentulous and dentate and UK dentate samples from big population surveys where OHIP 14 was used. And actually, it was pretty simple analysis in a sense that, you know, it looked at the combination of responses. And it actually showed that in the population level, the model on the left, so the gray arrows actually didn't exist on these two populations, or actually three populations if you take the edentulous and dentate differently. But there were other lines, the black lines, which were, you know, present on those samples. So the theoretical concept, original theoretical concept, probably is not that good, but it's good enough. And you must always bear in mind, and often the OHIP or actually any quality of life measure brings very skewed distribution, so have to be careful while handling on that. So means are not necessarily at all good in, you know, the only measures or estimates. We can also monitor trends in populations, and we happen to be lucky enough in Finland that we had a 10-year proper, you know, national level longitudinal follow-up where we measured different self-assessed issues like self-assessed oral health using a single question with 5 response alternatives, self-assessed treatment need, and 3 different outcomes from OHIP 14 measure. So the prevalence of, you know, impact when you report at least one impact, occasionally, very often, or very often, or the extent that how many of those 14 impacts you have. So it counts the range of the impacts or the severity where we actually use the mean. But you can see here that the result as such is that, you know, the oral health related quality of life had improved on the average somewhat, but actually the differences are not that big, that they don't reach the Locker's 5-point difference. But on a population level, the trend is clear. You can also look at the causal relationships. So this is very interesting study from the same data by Eva Torpasaarinen, and I recommend you to look at her other papers and look for her thesis on the net by her name, because she really had a public health approach to the quality of life, trying to figure out that actually can oral health related quality of life predict regular service use. And here is the POF analysis on that. Well, the effect sizes we can see here, they are not very big, but it seems that better oral health related quality of led to regular service use rather than vice versa, which is one example of the paradox in oral health, that actually those having better oral health use services more often. Then we can also evaluate from the same study the effects of health and social policies on the oral health related quality of life, because in between these studies, there was a major oral health reform in Finland. That was in 2002, targeted especially to those born in 1955 or later. Before that time, they were not entitled to the publicly subsidized oral health care. But after that, they were entitled, and they were entitled also to use public oral health services, which are used commonly in Finland, about 50-50 in adult population. And this population also got reimbursement from social insurance from the social insurance company, from the private services. And again, you can see statistically significant differences, improvement in oral health related quality of life. And you can see that actually there are the change is bigger in the older age groups than in the younger ones, except for the men here. But again, we can discuss whether these changes are, how important they are. On the other hand, if we look at the trends in big populations, the trend is good, and we might say that something has happened. Then Eero used a sample which started from the 2000, after the 2000. These are also population level samples using OHIP, not exactly the same one. And he looked at whether, which is very important in public health, whether the social policy had any effect on the inequality, so whether it reduced inequalities. And we could see that the oral health impacts were concentrated at all study time points among individuals in lower income. And actually, the most of the inequality was related to specific general health, not oral health, tooth loss, and income, so 85 to 100%. And there was some change, decrease in the oral health related quality of life, so it improved slightly, but there was no dramatic or clear change in inequality. So even though there was an improvement, which is a good thing, the inequality mainly related to economics, low income, was still present. This is one of the most interesting studies, and I'm really, it goes with me all the time. Ann Sanders was very much, the leading. She's a sociologist and leading on that, and she used Korpi and Palme typology of different types of social welfare systems. So this is used, this study used data from Australia, United Kingdom, Finland, and Germany, all using OHIP, and looking at the inequality, so the income gradient. And you can see a clear income, rather clear at least, income gradient, so that those belonging to the lower income group had poor oral health related quality of life than those in the high income group, except Germany. And this is an interesting question. We know from Finbar's presentation that tooth loss and the way how tooth loss is treated might have an impact on that. So it could be something to do with the oral health care provision. In Germany, fixed prosthetics have been much more common compared to Australia and especially in Finland. On the other hand, even the social policies. So I think the main message is that the way the welfare state is arranged may affect the inequalities, and something in Germany had an effect that oral health related quality of life was similar in all of the income groups. Finbar already also got some information of this study. How do age and tooth loss affect oral health impacts? And this paper was, I think, among the first, or not maybe the first, but among the first to report and to show the impact of tooth loss. And actually, for example, in Finland, this was one of the big studies, referred and showing that we need 20 functional teeth. And this support of the current guidelines in Finland. So this kind of population studies can work also in basis of what kind of treatments can be seen. Of course, this is not the only one, but these are there to support that. This shows the results from Finnish National Survey in terms of coming back to also to the dentate removable dentures and full dentures group. So we compared these groups, and this shows very simply this figure that those with full dentures, this group has on average most of the impacts that they have on the higher level, and you can, my mouse always does funny things, so I need to use, so you can see that actually the problems in eating are more prevalent than that, while the painful aching is the most common impact on the dentate group. And when we were analyzing this with Lisa, this was really because, you know, the figures were showing us funny things until we find out that there was an, you know, modifying effect. So the age modified the effect of oral health related quality of life, effect of education. So in the younger age group with basic education, so, you know, there was this effect, but in the education, but in the older, that was not there. But the denture wearing was even more interesting, because among those with 20 or more teeth, wearing removable dentures, you know, they had poor oral health related quality of life. They were more likely to report oral than those who did not wear removable dentures, while those having fewer teeth, for those dentures were improving their quality of life. So very interesting population level that results, which also had some impact on our current care guidelines. Orthodontics. Malocclusions are always very, sometimes a bit controversial in the public health, or they used to be, because, you know, they were considered more aesthetics, while we know that that's not the case. And this is the study on the adult population, how the current malocclusions affect their quality of life. And this was really adjusted for several other things affecting oral health related quality of life, like decayed teeth, periodontal pockets, number of contacting tooth beds, previous orthodontic treatment, and self-perceived health. And we could see that the effect was different between females and males. So for females, having some malocclusion made the oral health related quality of life poorer, while among men it was only if they had increased overjet, looking maybe what they considered being feminine. Of course, you can identify target populations, but you can't do any decisions based on this, on what kind of treatment you should provide. On the other hand, another example of a study which was started before oral health related quality of life was, you know, very much on the floor. And this is by Anna Sofia Silvola. And she looked at publicly funded orthodontic surgery and the change over 5 years on their quality of life. And now you can see a huge difference. So it goes far over the 5 points suggested by David Locker. And actually, to mean 4.1 is very close to population, you know, average on that age group. So this was used as a saying that, you know, this really had an impact. And you can see that especially the impact was in decrease in physical pain and psychological discomfort on those people. So, okay, we know that, you know, things are, and we can go back to the discussion about the methodology and what kind of measures we need. But I think, you know, the most important thing is on the population level that instead of going deep always to find better measures, we use the oral health related quality of life measures as an advocacy And they are not like, I like this Sir Michael Marmot's quote, that they don't need to be discordant with each other. And do we need then, I need to ask a question, do we need oral health related quality of life measures? I didn't go very deep into quality of life, health related quality of life, and oral health related quality of life. But interestingly, there were not much studies on doing. There is always this introduction that these are concepts which, this major concept, another, and oral health related quality of life. So we could argue that actually oral health related quality of life is not needed because we can use a quality of life measure on population studies. But this is not what we can do, because this is a paper by Katri Palo. Hey, Katri, I noticed you are over there. And she looked at another population, a fin-brain cohort, the oral health related quality of life measure, and OHRQoL. And as you can see, in most of the dimensions, the correlations are just really minor. And even in the total scores, they are different. So they capture different phenomena. So if you want to look at the changes in oral health, you need an oral health related quality of life. That's my opinion. Well, many of you might be in a situation that you would like to do population level research. So how to get oral health related quality of life measured in population studies? So you need to get networking and advocacy to get the measure in another major survey. You have to select feasible, valid, and reliable oral health related quality of measure, if possible. And I will give you an example of our situation. There's a very good a systematic review by Riva. George, you were on the paper also, on different quality of life measures. So that's a very good way to start looking at what's been done, what's been used. But you have to think about what's the purpose of your study, because you can't do everything with one measure and necessary, like Finbar said, you have to choose the questions. But on a population level, you have to think about, okay, do we want to look at the comparisons? And then you have to tackle the compromises as good as you can, because I tell you, things were not all I have shown you beautiful results, how the Finnish health survey was done. But what happened? We find out that we might get the measure in. So we had to start quickly, because Finnish is a language which is not often used. We had to start quickly. So I had met David Locke. I asked David, I need your help. I need to get a measure. So he got me in touch with Gary Slade, who immediately sent me a copy of OHRQoL. We started the translation process. And we have to rush. And, just with the pilot results, we had to push it in to trust that it was reliable enough and have to do everything afterwards. Okay, what happened then? The thing was in, data was being collected. And all of a sudden, we found out that actually we used a different recall interval. So we used 1 month recall interval, and the other national surveys, UK and Australia, had used 12-month recall interval, which is a big difference. Can we compare? Okay, so we had to do another small study to look whether these are comparable enough. And you can look at the Sutinen et al., what we did. And that was the first time I learned how to do a randomized crossover design in a convenience sample and another sample. And I really, really much also think that we should get oral health related quality of life routinely measured in health systems. What these national studies have done is that, people have noticed that actually this is an important thing to measure. It's not only for researchers. And I know that very many university hospitals nowadays use it routinely. It's part of some of the public health centers, and it might get, I'm busy working on that also, so it might get into our national electronical population recording system. So with these words, I thank you with a couple of pictures of my quality of life. I live very close to a big lake. It's only 15 minutes walk from so we can go for a swim or we can go to skate. They make a nice path there. So thank you for your attention, and we are now ready for any questions.
Thank you very much, Satu. That was really beautiful as well. And I said, not an easy bar to follow after Finbar, but yeah, you did a lovely job and touching the issue from a different perspective. Please put your cameras on and let us know if there are questions. I hope there are quite a few questions because you've been listening patiently for an hour or so. And there are so many topics that have been raised. I mean, for a start, we found out that how Finbar defines quality of life is very different from how Satu defines quality of life. One does sea and sun and sunsets. The other one does swim in a cold lake. But yeah, and please, you can also use the chat as well. Can I, while waiting for questions, for either hands or something in the chat, can I kickstart the discussion and ask Finbar first? You've raised the value-based healthcare sort of frame of approach of thinking about health systems and a number of stakeholders. And I was wondering, where do quality of life or subjective outcomes fit in there? I mean, can we use them at all? Who would be the stakeholders, would be proponents of that? Where do they fit? Because all the healthcare systems now are about value-based healthcare. Are they useful outcome measures? In what sense exactly?
Thanks, George. Yeah, I guess an example that I can share with you is the Utah healthcare system in the United States. They developed a concept known as value-driven outcomes. And in that, there's a series of measures, but including some form of patient-rated measure. That can be satisfaction, it can be global ratings of change, it can be some form of appropriate quality of life measure, and that I have to use that in as loose as possible terms. But I think that is up to the individuals who are setting the bar. So in Utah, they use it a lot for measuring surgical outcomes, medical outcomes, and the idea is that they want to develop. There is patient input into the metric, which is the outcome side. Obviously, the cost is the cost, and they calculate the cost, and then the value is a ratio of outcomes to cost. So the outcome side of is usually the numerator in that equation, and it does include some form of patient-rated measure. It doesn't specifically have to be a health status measure or quality of life measure, but it is critically, it's a patient-rated measure. So I think that we can use them in that way, and I think where you have a variety of different treatment options at varying costs, I think, and obviously a variety of standards of care as well, by the way, depending on the skill level of the provider. I think this is a way of capturing what can be achieved at what cost. And then from a sort of an institution or systems level, you can look down at that and see, okay, well, how can we drive value into this? But it critically has to have a patient-rated measure, and that is in the value-based care system, that is an important component which up to recently has been missing.
Thank you. And I mean, I take it and use as one example, but Sati, you were also referring in your last slide, you were saying we have to use them routinely in the health system. Let's say we do. And what is my question? How do we set targets? Finbar went a step further and he said we can have cost effectiveness of interventions. But if people haven't used them in oral health, how can a group like this one, it's a European Association of Dental Public Health, people are interested in the topic. How would you suggest we go ahead, and what would be the main caveats we need to be mindful of?
Actually, this is a big question, but I think, following what Finbar said, we might get 2 treatments and we find out that they could be actually about the same cost, but patients value the other one more. That's one very simple example that, where they can be used. But, and I think this is what has happened a lot in Finland, for example, in certain operations, in surgical operations. I'm not talking about oral health, because I think we are a bit behind from other health areas of health where they have, routinely used this. Thinking of, for example, that, my old mother was in a back operation. So she frequently receives a questionnaire asking about her quality of life. And they make also decisions on whether the patient will benefit from this, assessing their quality of life or any patient-reported measure. And if you think about what we should do, we should have some basic information, or we should do advocacy from the information we already have from other studies. For example, inequalities, something like that. But it's a big thing.
It is a big thing. And there's a message that you can put questions in the chat. I'm more than happy for people to just ask a question, and please, turn the cameras on. And if you want to ask a question, we don't have to have a discussion of 3. We are about 50 in the room, or the virtual room. It is a big question, but I was wondering whether that big question, if other disciplines, and you mentioned sort of outside of oral health, are using it, it means it's feasible. I cannot see why oral health could be different in that respect, if I may challenge you for the opposite.
Yeah, I agree. It shouldn't be different. So I think the thing is, I'm afraid that, sometimes we think we are too busy, we don't have time. But I see there is a question coming.
Yeah, Jonathan, do you want to ask your question rather than write it, please?
I'll ask my question if that's okay. So hi, thanks both very much for that. One of my roles is editor of BDJ Open as one of the, and I get quite a lot of a few submissions translating the oral health related quality of life metrics into different languages and things like that. But I'm also interested in if you think we'll ever get to the stage where we can compare oral health quality of life between countries and between cultures. So if any of us were to see a research paper that said, oh, well, we did this study in one country and this and compared to another country, do we think that the metrics are suitable to use to compare between different countries? Or if we were to see research like that, should we take it with a big pinch of salt and assume that some of them are a bit culturally sensitive, I suppose? I don't know who's best to answer that. Thanks.
Both is my answer.
I think, Jonathan, you are just referring to what I said, that it's an endless road. We can say it's not. There is always that it's not comparable because there are cultural, but up to what level we need to, because, for example, referring to the Sanders study. So my worry is that if we go too deep, we are not doing anything. And what's the use of comparing with the oral health related quality of life? So I don't think, you know, we shouldn't measure the absolute figures, but are the trends, are the inequalities similar? Because, you know, nowadays, I think within each and every country, we are having subgroups, cultural groups, and so it's very difficult if we want to do it perfect everywhere. But what is good enough? And I hope, Finbar, you do have an answer.
Thanks, Jonathan. Yeah, I mean, to be honest, I've never seen a huge value in really comparing across many countries, because I think every country's subjective health assessment, if we want to call it that, is going to be influenced by obviously the cultural makeup, the cultural diversity within that country, but also there's a strong influence of things like educational system, healthcare services systems, and so on. So I don't personally see a great benefit in comparing like that. Having said that, Satu presented some of the data that we developed all those years ago, which I think was useful. Because but like you probably noticed that we subdivided it into each country. So in a way, we weren't comparing across countries. We were actually just using all those countries' data sets to answer a specific question. So I think comparing quality of life outcomes in one country with 4 or 5 different countries, I personally don't see the benefit in it. I just don't see the benefit. So yeah, I guess no would be my short answer to your question.
That's great, and it's always good to get a more definitive answer. So that's really, really helpful. Thanks very much.
Thanks.
Can I jump in on that, Jonathan, if it's okay? Yeah. Because I mean, you hit a sensitive chord there, because I think one problem we have had in the field, and you will realize that the quality of life lot are quite self-reflective crowd. They always ask, so what, and why should we do that? And they end up saying, yeah, it's a nice thing to do, in a not very convincing way. We have tons of studies, and I raise my hand, I'm responsible as well with others, I'm not alone responsible, that they say, oh, we will adapt the measure for X country and then for Y country, and then on and on and on and on, you know. You go through the list of the world, wherever you can have a study. And I think when you receive them as an editor or associate editor, you think, so what? Why is this part of an international debate? It's a very relevant step to have a measure used in that country. But surely is the methodology we apply time and again and again. I think if we are using, and we're using those measures in many countries, yeah, or HIPPO, IDP, Go High mostly, but all of them, we use them. We might, unless we check the cross-cultural equivalence, which is another psychometric way of doing it, we might be saying we use the same measure in 2 different countries, but the measure might not be exactly the same or tapping, meaning exactly the same in the different contexts. Is this a problem? Yes and no, I would say, because to me, it feels it's like riding a bicycle. You know, we get endless into the psychometrics. Unless we get it perfectly right, we cannot really use it. And I think that's a problem. You need to use it knowing the problems and getting it right at the same time. Otherwise, you will never apply those outcomes for health services evaluation, for any policy evaluation, or for even clinical studies. So what I would ask people is not to not use them, to use them, but be a little bit, exercise scholarship when they use them, and be mindful that this is not the silver bullet that will solve our problems, because they are not.
And I think, you know, just jumping out of this thing a little bit further, I like back to the question you asked, you know, that why and where to use. And I really like the approach of Eva Torppa-Saarinen, that can these measures also be used finding groups in need of treatment? because we tend to have those with good oral health, as we saw on the longitudinal. So good oral health leads to regular services. So those, and could it be kind of a screening, for example, within the health system, that we find out? So when you are asked, like in Finland, we use an electronic system, fill in your symptoms. And actually OHIP is within one of those that fill in your symptoms. And if you report certain, so they're pilot testing that if a person reports this, should she or he get a appointment with the hygienist, see a dentist, or just get some, go to this website and keep on doing a good job with your teeth. And unfortunately, this pilot hasn't been published, but I think, it's another thing. So it's not effect of treatment, but trying to identify people in need in other places that, if you report really high impacts, something is wrong. And then we need to get you to see oral health people. And for example, they were applying that in a diabetes. The diabetes nurses were applying this kind of measure. So it was used for screening, which I think is a very interesting and different approach.
Can I just also say that I think coming back to my point about how these data are reported is actually quite important as well, because if you look at macro population level data and you see all of these means and so on, if you don't drill down into those data, then it can actually be quite misleading, I think, or interpreted in a misleading way. So for example, Carol Wanitsa-Harena and George did this paper that I was on a few years back, where we looked at, it was like a quasi cohort study using the UK adult dental survey data from two of the surveys. And if you looked at just the top level comparing, because there was only OHIP data used in 2 of those, it looked as, oh yeah, been an improvement across the system. And if you just had reported it that way, it would have looked, yep, oral health's improved from a quality of life perspective in the UK. And at a top line, that is actually true, but actually it had deteriorated for a substantial portion of the population. And it was, of course, in, as you might expect, the lower socioeconomic groups. So that nuance could have been missed if those data were not reported that way. So I think there is a value in looking at systems and quality of life data, but I think how they're reported is very important. So you're just looking at the descriptive reports using the standard means and medians. I don't think we should accept anymore. Personally, I think we should insist that authors, no, you must drill down and break these data up and show us the subgroups and how they're affected, because I think that was a really powerful piece of work, I feel, and I think good practice would come if people looked at that properly.
And in a way, there's different levels of it, isn't it? I'm thinking in an English context, you wouldn't come and say this is an overall figure, and you would have everyone saying, oh, we need to commission services. But an overall figure from the Children's Dental Health Survey was surprisingly for me, back in 2013, was the highlight of the survey. The newspapers picked up that, oh, almost 1/3 of 12-year-olds are embarrassed to smile because of the teeth or something like that. And suddenly oral health comes to the fore of the political agenda. That's good for advocacy. But if you want to plan services, that overall figure will not tell you much. If you go to any board that wants to commission services, they say, okay, we have a problem, but who exactly has it? And what can we do about it? So you need that level of granularity, that level of detail that Finba is talking about to help people make policy decisions. Yeah. Academics can still write papers. It's okay.
Yeah.
George, can I just ask a question around special needs populations and the use of oral health related quality of life to the panel? So it's been under-researched and underused. So I don't know what your thoughts are. Thank you.
I don't have any great experience in that particular aspect, I have to say, but I think you're dead right. It's an under-provided for area. I certainly think it should be looked at. And again, I think that if David Locker, God rest him, used to say these things give people a voice, and I think that's what they would do for special care, special needs groups. If we had more data coming from those patient groups, which could extract the difficulties they have with their oral health problems and accessing services, etc., I think it would be probably a more powerful tool for advocacy than us as dentists or dental care providers. So from a methodological point of view, again, the construct validity of these would have to be tested, I guess, in those populations, but I don't think that's an insurmountable issue. And in addition, just as a final point to the actual patients themselves with the special needs, I think their carers and provider guardians would also have a view that could be captured that would be useful, as is used in some of the parental caregiver questionnaires for children.
Satu, do you want to add?
No, I don't think there is anything more to add to that, because I also agree it's important, and this is actually then a difficult thing when you go to the validity and whether you get the parental and again then you have to make, so it's a question about whom you compare and what you do. So it's, but I think the most important thing is that, like you quoted David, to give them a voice, to give the patient, any group, a voice. And I think that's the most important thing quality of life measures are used for, or any patient reported. We are doing the service for people.
That's a really nice line. I can only add to that I think Huda's question taps on an issue that is totally under-researched, and I think there should be exactly that, the topic of another webinar. And I believe we shouldn't be surprised if we realize that the measures we have for the general population are in themselves not fully appropriate, and sometimes can be seen as, I don't know, offensive, but completely off the mark with the lived experience of what we call vulnerable populations. So I'm a bit mindful to just throw an OHIPO or IDP to a group just because it's validated in the general population and assume it will capture more or less the key points that a special care group or a vulnerable group would have. I think that's not the case, and it almost feels a bit paternalistic. It feels like we know what you should be thinking about. We know for the general population because the measures were developed through qualitative research on general population samples. I don't think we know in specific population groups.
Great.
Yeah, I agree. And I think, the qualitative development, processes were not even touched. So we kind of give the idea that this is a question about, the statistics and everything. But actually, I think a qualitative approach is very much neglected in many cases. Sometimes a good qualitative study can give you much more information, especially on special groups. And you don't even have to think about the approach that should we compare it. So there are, and I think it's always a question of interpreting. So you understand what are your measures, how you use them, and what pros and cons they have.
Barbara.
Yeah, Satu gave a bit of a thing. I was gonna jump into what Satu was just saying, reflecting on the question from before. I've tried doing OHIP questionnaires with nursing home residents. It just doesn't work. After 5 questions, they get bored. They ask when it's finished. Then they start answering randomly. Everything goes in the middle. You don't capture anything that is going on, or at least that's my experience. So I would strongly recommend doing some qualitative research, and you can be inspired by the quality of life instruments we have for the general population for your interview guide when you start your qualitative research. But I have a feeling that in those vulnerable groups, yeah, they just have a different set of priorities, a different view, or like a different way of looking at things. And it's very difficult to capture those in the standard sets that we have now for the general population.
I think from a methodological point of view, it would be a great study. It'd be quite tricky to do. I think, Barbara, the answer would be going into the qualitative side. I agree with you. My experience with some of the late stage elder patients, you just don't get usable data from using OHIP 49, for example, or even OHIP 14 is a bit iffy. So yeah, I think we have to take a different approach. We can maybe use the empirical frameworks that are out there to base any measure on and triangulate that with qualitative research. I think that could be an approach. But I do think we do need to look at this quite carefully, because it is definitely an area that's missing in our quality life research agenda.
Would a long cycle round, but has the point been answered? Okay. Any further questions? I'm mindful that it is quite late for people, particularly not for us in the UK, but almost everywhere else in Europe. And the Easter you go, the more dinner time it is.
Yeah.
If there are no more questions, and before passing to Huda to close the session, I want to say a really big thank you to both speakers, because you've done an excellent job raising a number of issues in a very logically coherent way, and you had the flow and you allowed for a very good discussion. But I also want to say thank you to the EADPH board, of course, and Huda, but I think specifically I feel I need to say thank you to Danielle Barrett, and she's done an excellent job setting everything in place, and Anna Vukovic, I think, but I may be missing who did the job. This is what my perception is from everything, and I want to thank so many of you attending a late evening session. And I hope we can have another discussion in the future, but Huda, over to you. Thank you.
Thank you, George. Thank you for facilitating the speakers, for coming up with the program. Thank you to Finbar Allen and Satulati and all of our members and non-members for attending. And this is not advertising, but I hope to see all of you in Crete, 3rd till the 5th of October. We've got our EADPH conference on commercial determinants of health, and we've got a very exciting program. Thank you very much. And Satu, I hope you go and get your dinner. Thank you. Sorry for the delay. Thank you, everyone. All the best. Take care.
Thank you, everyone.
Thanks for attending.